So quickly, the definition of resistant hypertension. So there are a number of definitions, and of course, the prevalence of resistant hypertension varies depending on the definition. But the commonly used ones are BP not on goal when the patient is taking 3 or more antihypertensive medication, including a diuretic if possible. The other definition which is also used is if the blood pressure is controlled, but you're using 4 or more antihypertensive agent, that's also considered resistant hypertension. Why should we care about resistant hypertension? We have published a number of articles looking at impact of resistant hypertension on various group of patients. This is data on resistant hypertension and patients who have coronary artery disease. So when you compare patients who had resistant hypertension to those who did not have resistant hypertension, you can see that patients with resistant hypertension had worse outcomes, significant increase in major cardiovascular events, coronary heart disease related events, non-fatal MI, increase in the risk of stroke, major coronary events, all-cause mortality, coronary, any cardiovascular events, any coronary events, angina, and need for coronary revascularization. So if you have patients with coronary artery disease and they have resistant hypertension, they have markedly increase in the risk of cardiovascular morbidity and mortality, including an increase in the risk of all-cause death. What about patients who do not have coronary artery disease? I mean, this is another publication which we used the ALLAT trial to look at patients who had resistant hypertension in that trial. And as can be seen here in various different models, the story is very similar that patients who have resistant hypertension, significant worse outcomes, even if they did not have coronary artery disease at baseline, including higher risk of end-stage renal disease requiring dialysis. So there is a risk of cardiovascular, cerebrovascular, and renovascular outcomes if you have resistant hypertension. So what do we do with these patients? The step one, multiple speakers have kind of alluded to this so far. The step one is actually to confirm diagnosis of resistant hypertension. And of course, I mean, you just have to make sure that the blood pressure measurement is accurate and the measurement is taken when the patient is rested, etc. Also check for white coat or masked hypertension, and again, the guidelines emphasize using out-of-office blood pressure measurement, whether it's ambulatory blood pressure or home blood pressure measurement. Also review salt intake and use of NSAIDs, especially in older patients who may have arthritis and may be taking a number of different medications. Also ask the questions, are there adherence concern? And if the answer is potential adherence concern, consider urine or serum drug screening or do observed drug dosing. And also make sure that there is appropriate use of diuretics. Critically important is to rule out secondary causes of hypertension, and obstructive sleep apnea is one major cause. It's important to assess for daytime sleepiness. I mean, there are a number of questionnaires which we can use. You also can do a home sleep test using a portable sleep monitor device. The other rule out other secondary causes including renal parenchymal or renovascular hypertension, urine analysis, serum creatinine measurements, or renal duplex for abnormal findings. Primary hyperaldo is one of the major ones which is commonly missed, so I think it's important to have a low index of suspicion, use plasma aldo-renin ratio for diagnosis of this. And again, medication non-compliance is one big factor for all of this. So once you have confirmed that the patient does have resistant hypertension, the step two is to switch. Dr. Nair elegantly pointed out, it's very prevalent for patients to be on low doses, low potency medications, and so it's important to switch lower potency agents to higher potency agents. Within a class, for example, this is looking at ARBs and systolic and diastolic blood pressure goals. And as you can see here, many a times, many of these patients are on losartan. Losartan is one of the weakest antihypertensive agent, as you can see here. So just by making within class switches, you can see that their blood pressure gets better controlled using more potent medication, longer acting agents. That would be the step to see if we can fix this. Step 3 is to, in patients who do not have compelling indications, discontinue beta blockers if they do not have a compelling indication, because the data to treat hypertension without a compelling indication with beta blocker is weak. And if you look at the prior paradigm, 10, 15 years ago, if you look at all the guidelines, they endorsed beta blockers as first-line therapy, but multiple analysis, we have published a number of these analysis, beta blockers in hypertension, no significant benefit. If anything, there was a worse increase in the risk of stroke when compared to other antihypertensive agent. We saw similar results from the ASCOT BPLA trial looking at atenolol versus amlodipine. Clearly, amlodipine was superior. Atenolol had higher death and stroke. So if you're using beta blocker, use vasodilatory beta blocker, nebivolol, carvedilol, etc. So as such, I mean, now there is more uniformity in guideline recommendations, beta blocker for hypertension. Most of them relegated beta blockers to either a third or fourth line therapy for the treatment of hypertension. So as fourth step, I think this is critically important because if patients have resistant hypertension, you can imagine that they're already on a number of different agents. So simplifying drug regimen and the use of single pill combination is critically important. Interestingly, we've been part of a number of renal denervation trials, and one of the things that we used to do with the renal denervation trial as part of the protocol is to take them off all their medication and switch it to a single triple pill combo. And with just that simple maneuver, what we have seen is during the first month of the screening phase, nearly 40% of them have their blood pressure controlled and they drop out of the trial. So it's critically important. We know from a number of trials that most patients need multiple medications to reach blood pressure goals. As you can see, at least 2, and in many cases 3 medication to achieve blood pressure goals. And as the number of medication increases, the risk of polypharmacy and medication non-compliance dramatically increases. And it's also important not just to look for prescribed medications if the patients are taking over-the-counter, it could be vitamins, herbal supplements, etc. That also adds to the pill burden and can potentially decrease compliance to medications. And clearly, drugs don't work in patients who do not take them. And a number of studies have shown, this is a pretty old meta-analysis that we did now more than 15 years ago, looking at single pill combination and compliance. Clearly, single pill combination therapy significantly improves compliance. Of course, initially I would say that there was a lot of resistance because we didn't have much of the single pill combo as a generic pill. Now we have a number of these, even including those which are a triple pill combination. So, and the guidelines uniformly endorse using such a strategy to improve compliance. Step 5, after all of this, is to add medication based on underlying mechanism. So it's important to categorize patients as, is it driven by volume expansion? Is it driven by increased sympathetic activity? Is it the hypertension driven by increased arterial stiffness? One of the things to strongly consider is the use of an MRA. And especially at the higher doses, they have been shown to be very potent in patients who have resistant hypertension. And finally, it's important, I'm not sure the availability or penetrance of renal denervation here, but at least in the US, we have had a number of clinical trials. So it's important to identify patients who may benefit from advanced therapies, including renal denervation. Just quickly going over renal denervation. So if you look at the first generation trial, the Simplicity Hypertension 2 trial, there was a significant decrease in blood pressure, 32 millimeters decrease with renal denervation, and there was hardly any change with controls. But in a more definitive trial, the Simplicity Hypertension 3 was done. When you compare it to sham control, there was not much significant difference between sham and renal denervation. Even though the renal denervation reduced blood pressure, so did sham. And as such, Simplicity Hypertension 3 was considered a negative trial. Franz Maserli and I wrote an editorial for Simplicity Hypertension 3. At that time, we said the time has come to turn the page on renal denervation, but by all means, let's not close the book. I'm glad we did not close the book. We persisted. We learned a lot of lessons from prior trials of renal denervation, including the very basic fundamental facts that how the nerves are distributed around renal arteries. So we now know that the nerves converge towards the distal part of the renal artery. They are far away in the proximal part of the renal artery. So it does make an impact if you're doing an endovascular renal denervation therapies. And here you can see kind of the variability in nerve distribution, proximal, mid, and distal. And this has led to several different changes in the devices we have. We have had experience with this Radiance Recore device, which is a balloon-based, ultrasound-based device, and it does pretty well in terms of achieving 360-degree renal denervation on these patients. So if you look at the second-generation renal denervation trial, and all of these had sham control, and they looked at ambulatory blood pressure reduction, spiral off-med trial when patients were taken off all their medications. Here you see a 5 millimeter decrease in ambulatory systolic blood pressure. In the Radiance Hypertension solo trial, which we were part of, 8 millimeter reduction in ambulatory pressures. Spiral on med, these are patients who are treatment resistant, were on medication but not controlled, 9 millimeter decrease in blood pressure. What we have seen from all of these second generation RDN trials, which were sham controlled and with ambulatory blood pressure, clear consistent reduction in ambulatory blood pressure when compared to sham. What we have also seen from a number of these trials are that the BP response can be seen over a period of time. So this is spiral on-med trial. At 3 months, the difference is 4 millimeter systolic pressure. This is ambulatory pressure. At 6 months, you can see a greater decrease, 8 millimeter ambulatory systolic blood pressure reduction with renal denervation when compared to sham. The one major thing I think which we should remember is the blood pressure reduction with the antihypertensive agent really depends on whether the patient takes their medication or not. And that can vary on a day-to-day basis. But with renal denervation, there is this phenomenon of always on. So once you do the procedure, the patients have blood pressure control, and that is not dependent on, unlike medication, it does not depend on medication compliance. So this always on phenomenon is likely will translate to significant reduction in cardiovascular outcomes. So this is an interesting slide which we created a while ago looking at ambulatory blood pressure reduction, comparing it to antihypertensive agents on the left panel to renal denervation on the right panel. So clearly you can see that renal denervation reduces blood pressure as much as single antihypertensive agents. And in many other trials, more than that. So this is my summary. So I think we learned a lot about resistant hypertension and how best to treat it. I'll end here. Thank you for your attention.